You see, we are moving fast, unfortunately, because in these 3 days we cover most of the big endocrine glands. We cover pituitary, adrenals, and thyroid is the next most frequently affected organ in endocrine diseases. And today, if we have time, or definitely tomorrow, we will do the parathyroid and calcium metabolism. One of the interesting things about hypothalamic pituitary thyroid interaction is that not that specific. ACTH, adrenals are very specific. And the thyroid system is a little more complicated. Look at the left-hand side. Of course, it starts with the usually hypothalamus, which releases thyroid-releasing hormones, stimulating the TSH, thyroid-stimulating hormones, to influence the thyroid gland to produce thyroid hormones, which are mostly T3, T4. One more thing to just reinforce that, because there is a lot of confusion about thyroid-releasing hormones. Previously, these were called thyroid-releasing factors, TRF or CRF, which is still used in some textbooks. That was used when they did not know the structure of the thyroid-releasing hormones. When the structure was discovered, then they can use the term thyroid hormone. And actually, TRH structure was the first one. That was Roger Gilman got the Nobel Prize, because essentially 3 peptides are essentially in TRH. And thyroid-stimulating hormone, we know the structure for a long time, so that's the reason it's hormone. But this was especially the releasing hormones called for a long time. TRF, not TRH. Now the problem is that with the adrenal thyroid interaction, especially it was discovered with the stress reactions, the glucocorticoids in acute stress affect the anterior pituitary, stimulating the secretion of TSH to secrete more thyroxine. And you will see the importance of this when we discuss in a few minutes the pathogenesis of Graves' disease, which is a hyperthyroid disease. And one of the triggers of this is stress. And that was discovered because of this non-specific interaction of the adrenal cortex, glucocorticoids affecting the pituitary to stimulate TSH. Chronic stress, on the other hand, has the opposite effect. It affects the periventricular nucleus, CRH production, and it also produces actually somatostatin also, which has an opposite effect from TSH. And here is a summary, the illustration of the 2 major diseases of thyroid. That's the only thing you have to know, because these are the most frequent. And the normal axis, of course, a beautiful balance between TRH, TSH, and thyroid hormones, making a beautiful balance. TRH, in Graves' disease, TRH secretion is inhibited because of excessive production of thyroid hormones. So how does it happen? Usually, if you expect a hyperthyroid functions, you think that it's coming from higher level of TSH, but it's not the case. Why? Because you will see in a minute in the mechanism of action of Graves' disease, that is a stimulatory antibodies which actually imitate the action of TSH to produce more thyroid hormones. Thyroid hormones released in the blood, much higher level, and because of the negative feedback, if you have more thyroxine, it inhibits TRH. So it's a very fun and unusual interaction. And that's the reason that in assessing thyroid function, you have to measure always TRH also. Not only T3 or T4, but TRH. The other disease in the thyroid gland is inflammatory disease, also autoantibodies, but essentially causing the opposite effect, not stimulating but destroying some of the thyroxine producing cells. And this is called Hashimoto's thyroiditis, which associated with high level of TSH and low levels of thyroid hormone because these are destructive autoantibodies which destroy the thyroid glands. So it is the illustration why not enough to measure peripheral thyroid hormone. We have to measure TRH because that gives you differential diagnosis of these diseases. How does it happen? The thyroid gland produces these two major hormones, thyroxine and thyroid. The so-called follicular cells are secreting the thyroid hormones, T3 and T4, and thyroid globulin also. What are the follicular cells? Follicular cells are these cells which are lining these colloids. And you will see later on why this colloid is important. It's not just empty fluid, but it's metabolically active side. So these thyroxine T3 are produced in these follicular cells in normal condition. And in a very active state, the colloid decreases and these cells enlarge and to produce more thyroid hormones. In adenomas, there is a monocellular proliferation of cells essentially separating from the normal thyroid with this the fibrous capsule. But this is adenoma, so that's good news for that. In Graves' disease, there are these lymphocyte-produced autoantibodies which are essentially scattered in the thyroid tissue and stimulating these cells autonomously, irrespective of the pituitary to produce more thyroid hormones. Graves' disease, there are also inflammatory cells, but they're destructive inflammatory lymphocytes, which are killing the follicular cells, hence you will have less thyroid in the circulation. One thing which essentially emphasized even now, that most of the circulating T4 is actually coming from the thyroid glands. T3 is essentially majority is converted from T4 to T3, and very little is produced in the thyroid follicular cells. There's another small cells which are here in the middle of these follicles, the so-called C cells, which secrete calcitonin, which is a polypeptide hormone which regulates calcium metabolism.
So is it T3? I'm trying to say that T3 is more active than follicle cells,
Yes.
and T4 is
yes.
inactive.
Yes, you will see why, because most of the thyroxine is bound to proteins. It's not very active, so only about 1 to 2% of thyroxine is free and gets out. But whatever gets out converted almost immediately to T3. So the active component is T3. But because of the high binding of thyroxine to thyroglobulin and albumin, it has a major pharmacological implication. So here is again a schematic illustration of these conversions of interaction between T4 and T3. And the other new player here, because these iodine is critical elements for thyroid hormones, dietary thyroid iodine is a critical component. So what happens? And under effect of TRH, the pituitary secreting more TSH to produce T4 and T3. But here it is, as I implied already, on the peripheral tissue, most of T4 will go to T3. Actually, the basic structure, you will see in a minute, of the thyroid hormones and essential thyroxine derivative. So it has either 4 iodine, coming from mostly from the diet, or T3, which is T3. But the metabolically active is T3, which is produced most in the periphery. How does it happen? Just look at the follicular cells. They are lining blood vessels in the thyroid glands, the big and large follicular cells, and the follicular lumen, which is the colloid, which I said is not inactive but very active. Why? Because from the diet, iodine is absorbed, get back through the colloid, through the follicular cells, then the thyroglobulins are synthesized, and and essentially stored and converted into either T3 or T4 and released. Most of the tyrosine is bound to thyroid binding globulins, and only the minority is T3. But in the periphery, most of the T4 is converted into T3. It is another important fact, which is definitely important for understanding both the pathophysiology and pharmacology. Only about 15% is produced in the gland, 85% converted in the periphery. Here is the critical elements which you should know for the quizzes and exams. Half-life of T4 is 1 week. 1 week. T3 is less than a day, about 18 hours. So T4 is extremely long circulation. That's the reason if you have a replacement therapy for thyroid diseases, you don't have to give weekly thyroxine, daily thyroxine. Weekly is enough. But here is another kicker. In the blood, 99% of the thyroid hormones are bound to proteins, carrier proteins. 70% is bound to the thyroxine binding globulin. 10 to 25% to albumin. 10 to 15% to another albumin called transthyretin. And about 2% to lipoprotein. So that's the reason that this is 99% of these hormones are bound. They cannot get out, and that's the reason the half-life is so long. And TBG is the major reservoir, of course, because it binds 70% of these. And when the thyroid gland is damaged or inflammation, essentially still have a reservoir for almost a week. How the hormones act on the peripheral tissue. Nice interaction of the pathophysiologic manifestation and laboratory changes, which are self-evident if you study this. The most important physiologic effect and in excess pathophysiologic effect of thyroid hormone is the heart. Too much thyroxine causes tachycardia, lipolysis, and proteolysis, so people lose muscles. In the bone, they promote normally thyroxine produces growth for infants into adolescents and accelerate the bone turnover. And in the nervous system, there are also essential development and maturation of infants and childhood. And in the intestine, increased carbohydrate absorption and increased intestinal peristalsis. Again, remember that the follicular secrete cells are producing this thyroid producing hormone and the transform and protein thyroglobulin. C cells secreting calcitonin. And thyroid diseases usually manifest in 3 diseases. Usually just enlargement, goiter, which essentially could be symptomatic or could lead to essentially diffuse Graves' disease, hyperplasia. Hypothyroidism is most often the hyperfunction of the thyroid gets caused by Graves' disease for autonomously, and hypothyroidism is the opposite. It's autoimmune thyroiditis called Hashimoto diabetes, which essentially is required by surgical resection, sometimes excessive or radioactive iodine for the excessive treatment. The most important take-home message is that I mentioned this on the first day. Among all the endocrine diseases, thyroid diseases are the most frequent. So you in pharmacy especially, you will see most of these patients, but about 5 to 7% of all the population, not the endocrine disease, but all the population. So we know from the outpatient clinic, pharmacies, hospital, most of the endocrine diseases are related to thyroid. Thyroid enlargement, non-specific portion, about 5% for the others, and hypothyroidism, unfortunately, is much more frequent in women. Congenital hypothyroidism is still occurring, 1 in 4,000 infants, especially areas which are deficient in iodine. Certain regions in the United States, Appalachian Mountains, were known to have low iodine in drinking that testing for TSH is the single most important diagnostic marker, both for hyper and hypofunction, as I explained before. This is always combined with the measurement of T4, T3. So most of the diagnostic clinics know this, but reinforce sometimes they forget to ask for TSH. They say thyroid, just measure T4 and T3. No, it's not enough. TSH is critical also. That's just to know that some drug-induced hyperthyroidism is becoming more frequent, and this is for hyperthyroidism medicamentosa, so hyperthyroidism caused by medicines. So here is the two main diseases. One is the hyperfunction, hyperthyroidism, which is for Graves' disease. And I'm sure you have seen patients with protruding eyes. Just curious, have any of you seen this kind of patients? No? You will see sooner or later. I encounter sometimes on the street. In European cities, when you are public transportation, you see people with usually women with protruding eyes. I can bear in with myself not to go to the lady that, have you seen a doctor recently or a pharmacist? Because they have Graves' disease. So if you see them, ask them, especially if you come to your pharmacy, protruding eyes is almost completely symptomatic to Graves' disease. It has a lot of other metabolic functions. Because of course, thyroid hormones, especially thyroxine affects metabolism. There is all signs of hypermetabolism because too much rapid turnover of proteins. These people are fatigued, heat intolerance, sweating, and losing weight and appetite. Cardiovascular changes are tachycardia because hyperthyroidism, thyroxine affects the heart, tachycardia, palpitation, hypertension, angina, and sometimes atrial fibrillation also. The neuromuscular changes, anxiety, irritability, emotional instability, muscle weakness. There's of course the reproductive system effects also, and women menstrual cycle changes, and men loss of libido and impotence. The most prominent approach is exophthalmos, the protruding eyes, exophthalmos, and corneal ulcers. This develops due to the fact that not only the eyes enlarge because it's retroorbital fat tissue and muscles proliferate under the influence of thyroid hormones, but there's not enough fluid produced in the eyes, and they dry out, and they have ulcers which are very painful. And the skin is mostly itchy. And here are the illustration which I just described. Lab findings are critical. Again, since you will measure all this TSH will be low because T3 and T4 are high. And the autoantibodies in the thyroid is the most important, which are producing this disease. Very often we say that we don't understand the mechanism of pathogenesis. And that unfortunately leads to a lot of diseases. But Graves' disease is one of them. The good examples that the pathogenesis is clear and understood. And that developed during the last about 50 years. First to know that Graves' disease is an autoimmune disease. Don't confuse with Hashimoto's, which is coming next. It's also autoimmune but completely different. Because here, the body system produces antibodies that cause the thyroid gland to produce too much thyroid hormones, T3 and T4. How does it do it? Because these antibodies attach to the thyroid gland cells, the follicular cells, and mimic the action of TSH. So TSH could be low, but these antibodies are crazy antibodies, stick only to the follicular cells and drive them crazy to secrete too much thyroid, and essentially imitating the action of TSH. These antibodies are called thyroid-stimulating immunoglobulins, TSH, which is different from thyroid globulin binding protein, or thyrotropin receptor antibodies, TRB. So just be ready to see these two different. high coming from? Mostly for B lymphocytes. That's the reason that the histology showed that there are a lot of lymphocytes, not as many as in Hashimoto, but there are lymphocytes in the thyroid gland which synthesize this thyroid-stimulating immunoglobulin, which imitate the action of TSH and driving the thyroid gland crazy. The funny thing is that several environmental factors, especially pregnancy, especially late stages, causes grave disease also. Iodine excess, infection, and emotional stress. You remember I emphasized the not specific interaction with the pituitary and thyroid because glucocorticoids affect TSH and thyroid hormone also production. And essentially those can trigger grave disease also. So it's crazy disease, very frequent unfortunately, but at least the pathogenesis is relatively well understood. So what is the opposite? That is hypothyroidism. It is also called myxedema because there is excessive polysaccharides deposited under the skin and it's causing a funny swelling. But the swelling is not due to water, but deposition of these polysaccharides. And it's called Hashimoto thyroiditis because it was a Japanese pathologist who discovered this. And here it's also very frequent, 1 to 100 in adults. And again, unfortunately, it's 6 times more frequent in women. And mostly caused by this autoimmune lymphocytic thyroiditis. And that is definitely not triggered by anything. This is totally autoimmune, out of the blue. And it's either has to be treated surgically or caused by surgical too much resection or when too much iodine treatment was applied to grave disease. So there's the borderline of treatment. You have to know the dose, what for medication, but for radiation treatment, it also could be quite basic. Try to apply to it sufficient radiation, but not too much. And the main result is what is slowing metabolism. Graves was high metabolism, Hashimoto is low metabolism. So not tachycardia, but bradycardia, somnolence, sleepiness, fatigue, cold intolerance. Myxedema is mucopolysaccharide deposited in the face, hands, and feet, all over the body. Resembling edema, but essentially not fluid, but more polysaccharide deposition. It could be so severe that it's called myxedema madness. And the other effect, of course, is that infertility, loss of libido, all illustrated here. So, the big summary of thyroid gland pathophysiology is that thyroid hormone production, T4 and T3, is influenced not only by TSH but also by dietary iodine, which is a completely new component. And only 15% of the T is produced in gland. 85–75% depends on the texture converted from T4 to T3 in the periphery. It's very important, circulate 2 times. Thyroxine half-life is 1 week. And this will be definitely the next week on your quiz. And 70% is bound to TBG, 20% to albumins and others. So essentially, there's a reason that more than 95% of thyroxine is bound to protease, quoting only the TBG, the specific thyroid binding globulin, which sticks with 70% of T4. Thyroid diseases are the most frequent endocrine diseases, far the most frequent, and affects 1–7% population. Hyperthyroidism, the grave disease, most prominent signs are the exophthalmos and tachycardia. Hypothyroidism is called Hashimoto myxedema, causes just the opposite effect, slow down the heart. Signs and symptoms of this clinical demonstration, manifestation is proportional for levels of T3, TSH, and especially TSH. this is the most frequent disease. I'm sure you will see it in your pharmacy sources.